think everybody knows me pretty much. I'm a social worker at Jefferson Hospital. I've worked previously both at Penn and at Kahneman before they moved.
And Liz reached out and got us our speaker tonight. So, Linda, why don't you go ahead and introduce yourself and explain, as you just did for Jerry, what that Einstein reference was in your bio.
Okay, well, I'm going to get to
the
next slide has who I am. The talk tonight is how to do a heart transplant. Everything you always wanted to know but were afraid to ask. And who am I? I am Linda Bogar, and I am a cardiothoracic surgeon. And I'm only one member of a big transplant team. We want to make that pretty clear. I am at Thomas Jefferson University Hospital. I'm assistant professor of surgery there in the Division of Cardiothoracic Surgery. I'm also the associate chair of Albert Einstein's Division of Cardiac Surgery. And I perform the transplants, along with a couple of them.
And Linda, just for your sake, this is one of a series of organ transplant surgeons talking about their specialty that was part of this library. So you're following the, what did we have last time, liver? Kim Altoff was liver. And we have kidney coming up, and so we're treating hearts tonight. So please, thank you very much for coming.
Sure. One thing I want to say, I apologize, I have the tail end of a little bit of a cold, so I apologize if I have to stop and drink or take one of my halls during the talk.
You're among friends, no problem.
Okay. So I thought I'd start off with a little background just so you know how people get to have a heart transplant. So some of the causes of heart failure I thought we could go over. The first one, and maybe the most common, is ischemic, meaning lack of blood flow to the heart due to blocked arteries. These are pictures of arteries. This is a normal cross-section of an artery. Here's one with plaque forming. And you can see as it gets built up more and there gets a thrombus in there, this could be a major problem in terms of blood flow getting through this vessel. Another cause is viral. A cold-like illness can cause heart failure. Another cause is postpartum. Sometimes women get heart failure during or shortly thereafter giving birth. And then the one we like to always claim is idiopathic, meaning we have no idea.
Linda, what about birth causes the need for a heart transplant?
We don't know. I mean,
labor or after, or because of the stress of labor on the heart?
I think it's associated with the whole pregnancy process in and of itself, not actually labor. But nobody really knows for sure. Of course, if we knew, we could prevent it and nobody would ever get it. That's what I always try to tell my patients. We don't know everything, unfortunately. So, obviously, the transplant team that I alluded to is a very big team. Consists of the cardiologists, who are the medical doctors who take care of the patients, cardiothoracic surgeons who implant the hearts, transplant coordinators who are nurses who help coordinate the transplants and help take care of the patients afterwards, social workers who are very integral in helping us prepare families before and after the transplants, psychologists, physical therapists to help people get back on their feet after the surgery, the nurses who are crucial to help taking care of the patients before, during, and after the transplants, pharmacists who help us coordinate the medications, which can be very complicated, dietitians who help us keep patients on track, eating properly, and clergy for spiritual support. I thought I'd just talk a little bit about how patients present to the transplant team. And although this is a busy slide, it basically just shows you that one way you could present to the transplant team is electively. You're a long-standing patient of a cardiologist who's got heart failure, and just over time the heart is failing slowly. And these people usually come and electively meet with the cardiologist and then meet the rest of the team and slowly go through the process of getting all the studies. Sometimes people have to present urgently that they're admitted to the hospital through the emergency room, they're in worsening heart failure, not responding to the oral medications, so IV medications need to be added, and the patient is evaluated as an inpatient and then either kept in the hospital or sent home, depending on how they're doing. Sometimes we have to emergently list patients for transplant. These would be patients who could possibly be undergoing heart surgery for either coronary disease, valve disease, who have weakened hearts and have difficulty coming off the bypass machine. Sometimes an extra machine needs to be placed in order to keep the patient going, in order to get the transplant. In this instance, the evaluation obviously happens at a much quicker pace. So the list, we all talk about the list. What does being on the list mean, and what are the status of the list? So status 1A, these are the patients that are the sickest. They're not expected to live very long, but they don't get a transplant very quickly. These patients need to either be treated with high-dose IV medications, or patients who have a mechanical failure or infection of their ventricular assist device, which we're going to go over what ventricular assist devices are, or patients on a ventilator. Status 1B patients are on IV medications or they have a VAD. Status 2 patients are stable and waiting at home. So just a quick tidbit about the history of heart transplant. The first human-to-human heart transplant was done in Cape Town, South Africa in December 3rd, 1967 by Dr. Christian Bernard. The recipient there lived for 18 days. They didn't have a lot of the immunosuppression worked out and most likely died of rejection. But there was a lot of research ahead of that transplant that led the way for that transplant. Most notably, Lauer and Shumway in San Francisco and Virginia, and actually Dr. Bernard trained under Dr. Lauer and Shumway, and everybody expected that they would be the first ones to do the transplant. But unfortunately, or fortunately, Dr. Bernard went back to South Africa and was able to do it ahead of them. In the 1980s, immunosuppression was brought on board, which dramatically improved the results of heart transplant. In the 1990s, we had the ventricular assist devices, which help us bridge patients to transplant and help us save more people on the waiting list who were dying. In 2000, the ventricular assist devices, we had a modification to them where they are non-pulsatile. And these devices are smaller, more easily implanted, and seem to last longer as well. So let's talk a little bit about the blood types. Why does it matter what your blood type is? Well, O's is the most common blood type in the country. O's are universal donors. They can give blood to anybody and give a heart to anybody. However, they can only accept O hearts. Therefore, it's typically the longest waiting time. Blood group A is the second most common blood type. They can accept organs from either blood type A or O. B's can accept organs from blood type B or O, and ABs are universal recipient. They can receive organs from either blood type A, B, AB, or O. So that's typically the shortest waiting time. So you have to talk a little bit about the donor hearts and how do we get them, because it's important to recognize that this is a process that involves another family that is undergoing loss. So unlike other solid organs such as liver, kidney, and pancreas, the heart must be obtained currently from beating heart donors. That could change in the future as we do more research and learn that the heart can be stopped for a period of time and still be usable, and we're working towards that. Brain dead patients are the patients that we take the hearts from, and brain death, you have to understand, is equal to death. These are patients who have isolated brain injury with preserved other organ function, and some examples I give are gunshot wound to the head, massive head trauma from a car, motorcycle, or boating accident, or people who have bleeds into their head from aneurysms or high blood pressure. They have to be judged brain dead by certain criteria. They either need 2 separate clinical exams by authorized physicians at a predetermined time period, or 1 clinical exam consistent with brain death in addition to a radiologic study, such as a nuclear brain flow study or a cerebral angiogram, which doesn't show any blood flow to the brain. So the donation process, how does it work?
Linda, can I interrupt you just for a
Yes.
second? Because quite a few of us are speakers, and we also have heard the exceptions to these, like donation after cardiac death, which is very heavily pushed around this area. It's not just from brain-dead donors.
For a heart transplant.
It has been done with hearts also, yes. And then we have the trivia that we always share with an audience, not always, of a person donating a living heart when they're receiving a heart-lung combination, the domino transplant. So just to round out the picture there, those are exceptions, but we know they're part of the process sometimes. Just to add that to it for me.
So if there's a patient that seems to be an acceptable donor, they are referred to the Gift of Life coordinators by the clinicians taking care of the donor. The Gift of Life coordinators go on site at the hospital, and all the appropriate studies are performed, such as blood tests for infectious disease. And as far as the heart, we need to get an echocardiogram, which is an ultrasound of the heart, and a cardiac catheterization for donors that are older than 40 or have a history of coronary disease or heavy smoking. Consent is obtained from the donor family by the Gift of Life people directly, not from the clinicians that are taking care of that patient. So how do we match the donor to the recipient? A number of things need to match up. Blood type, the level of urgency is the next. Size, we need to take that into consideration. A very small female heart may not be able to do the work for a large male patient. So we take all that into consideration. And also the pulmonary artery pressures or the lung pressures. We have to make sure that people who have a little bit higher pressures in the lungs get a heart that's used to seeing that, or else that heart's going to fail. So waiting on the list is either done at home, and of course you need to have regular visits to your heart failure cardiologist, or in the hospital, and the patients are optimized medically, they're getting their proper nutrition, physical therapy, and possible weight loss if need be. So what if the patient becomes too sick while waiting on the list? Well, the options are there to put in a ventricular assist device, which is a mechanical device that does the work of the heart. We now have implantable devices that can do the work of the left side. The right side still needs to do its job. These can serve as a bridge to transplant and get people through if a heart is not available when they become very ill. Here's some types of ventricular assist devices, which I'm going to call VADs. Temporary devices can be placed, such as this pump, which sit outside the body. There's also the option of a longer-term device, such as this newer device, that can be placed on the inside with only a small drive line coming outside the body. There are some disadvantages to having a mechanical assist device placed. It's a very large operation. It requires the patient to be hooked up to either a battery or electric outlet at all times. You need blood thinners for most of the devices, although not always. Sometimes we take people off of blood thinners for reasons such as bleeding. There's risks involved with the operation and with having the device later, such as bleeding, stroke, or bleeding into the belly. And it makes transplant a little bit more involved because you have to go back into the same area and there's scar tissue. So let's walk through the recipient process of a transplant. So the patient gets a heart matched to them. The patient will arrive in the OR, and a catheter is placed in the artery, either the radial, which is in the arm, or the femoral artery in the leg, to monitor the blood pressure more accurately. Then we wait for the word that the heart is usable from the donor team. Procuring the donor heart, members of our transplant team go to the hospital where the donor is being treated. Unlike other organs like liver, pancreas, kidney, we almost always go and get our own hearts because we like to assess the heart in person, see how it's beating, see what it looks like, make sure that the blood pressure has been good and stable. We travel by ambulance, helicopter, or plane, depending where the donor heart is located. Upon arrival, the procuring team verifies the blood type again. We verify that brain death has been declared appropriately. We verify that there's been proper consent obtained. And we look at the echo or the cardiac catheterization results. And finally, we visualize the heart ourselves in the OR. Meanwhile, back at our own hospital, the transplanting surgeon is now notified that the donor heart is good. So the recipient is put to sleep by anesthesia, with general anesthesia, which means a breathing tube is placed. And then a pulmonary artery catheter is placed to monitor the pressures in the heart and lungs. Then we wait word to start. At the procurement site, there are multiple surgical teams present. Depending on what organs are being recovered, there could be a heart team, a lung team, a liver, kidney, pancreas team, which could be one team or multiple teams. And so obviously working together is very important. There are areas that present challenges when going to get a heart, such as if the lungs are being taken, we need to make sure that we share parts of the heart with the lung team, because they need a cuff for the pulmonary artery and left atrium. And also the inferior vena cava is shared between the heart and liver teams. And so we need to be fair in our gathering of the organs. So once all the teams are ready to go, the heart team leads the procurement because the heart goes first. The heart is stopped with a high potassium fluid and cold that's applied directly to the heart. The heart is emptied of all the blood, and we give nutrients to the heart through the coronary arteries, which are the arteries that supply blood to the heart. That is not the correct anatomy of the heart. I'm going to show you what the correct anatomy is. So, I have to tell you a little bit about orientation of this. This is a view as if the surgeon was looking at the heart, okay? So the patient would be lying this way with the head here, the feet here. This is the right side of the patient and the left side of the patient. Okay. We have to carefully cut out the heart to make sure we don't damage any structures, make sure we leave enough size on the arteries and the structures that we're going to sew. So just a little anatomy lesson here. This is the superior vena cava, and this is the inferior vena cava. These are the big veins that bring the blood back to the heart. So this is coming from the head, this is coming from the lower body. These go into the right atrium, and then from there these go to the right ventricle, which is the chamber that pumps the blood into the pulmonary artery, which goes to the lungs. Once the blood goes to the lungs, it gets its oxygen and comes back to the heart through the pulmonary veins, which are here, and go to the left atrium, which you can't see on this drawing, and the left ventricle, which you can't really see on this drawing either, into the aorta and out to the rest of the body. Once the heart is taken out, you can see I'm holding it here. You have to be very careful so we don't drop it. Never happened. Never is. I've never done it. Then we need to inspect the heart on the back table, make sure that all the valves are clean and aren't torn or damaged in any way. And then we want to look at the division between the right and the left sides of the heart to make sure there's no hole. Because a lot of people still have the hole remaining that we're all born with that usually closes when you're a young infant. But if there's a hole present, we close it at this time or right before we implant the heart. So this is us just looking at the heart and inspecting it carefully. The heart is then carefully packaged in storage solution in lots of ice. We put it in a container, and then that container is wrapped in multiple bags and then placed in a cooler to go packed in ice for the trip back. Now timing of all this is key. And the heart should theoretically be in and working 4 to 6 hours from the time the blood supply is cut off to the heart at the procurement site. So we need to consider lots of things. If the recipient getting the heart is a redo, a reoperation, or has a ventricular assist device, that's going to take us a little bit more time to prepare that patient to get the heart. So we have to factor that in, and the travel time. All those things need to be carefully timed so that the heart is only outside the body for 4 to 6 hours before it's in and working. That's the time we feel the heart has best chance to optimally function. So now we've got the heart in our bucket, in our cooler here, and we're ready to go back. The patient at our institution is then placed on the heart-lung machine, the cardiopulmonary bypass machine, which drains the blood from the patient through, so here's another picture of the heart, through the superior and inferior vena cava, back to the machine. This is a real picture of the machine, which puts the oxygen in it, and then goes back to the patient's body, to the aorta, to the whole rest of the patient's body. This is the lifeline during the case.
Linda, from a timeline standpoint, the recovery team is out there, they've inspected it, they've given you word it looks good, but they're still in transit. I mean, they're either flying or driving, God only knows what can happen in the meanwhile. At what point are you at a point of no return on the recipient side?
When the heart is cut out.
So everything leading up to the surgery, opening up and everything is done in preparation, even though you don't have the heart on site?
Correct.
Okay.
It depends. It depends. If we're here in Philadelphia and the donor is here in Philadelphia, just a couple hospitals away, sometimes we wait till the heart's back at the hospital to even go on the bypass machine. But if the heart is 3 to 4 states away and they'll be flying back, and the recipient is a reoperation that will take 2 hours to, we call it chip away at the heart, meaning get in there, get all that scar tissue out and get prepared, then we need to start ahead of time.
Gotcha.
But the recipient's heart is not removed until the donor heart is in the building. That's the key. So you pretty much can always go back unless the heart's been injured in the opening process. So the recipient's body is then cooled to reduce the metabolic rate and the need for energy. And then the recipient heart is removed. Now, this is the most amazing sight to see when the chest is completely empty once we take the heart out and you're just left with these little cuffs of tissue to sew to. It's the most amazing yet eerie sight to see this empty chest. And this is what it looks like. Again, just reorienting you, patient's head here, feet here, right side, left side, the view from the operating surgeon looking in. So this is actually the left atrium. We always say that the heart should have been, the structures of the heart should have been named like anterior and posterior, meaning front and back instead of right and left, because really the structures are not on the right and left side, they're on the front and back. And the left atrium is in the back. These are those veins coming back and bringing all the blood back from the body. And so we have a little cuff of that to sew to, a little cuff of the superior vena cava to sew to, a little cuff of the left atrium, a portion of the aorta, and a portion of the pulmonary artery.
So you're actually leaving part of the heart in there to attach the new heart to, that left atrium?
Yes, that little cuff.
In a typical surgery? Yeah.
Yes. Yeah, you have to have, at least have that to sew into. The new heart is then opened and brought up to the field. Before the new heart is actually brought to the field, the blood type is again reconfirmed. The donor heart is then prepared for implantation. As you see, we have the heart here outside, and we're trimming the cuff because we have to match the cuff of the new heart to the cuffs that I just showed you. And then we look again to make sure there's no hole between the right and left sides of the heart. The heart is then sewn in place with sutures that are smaller than the size of a hair. And when we say that we sew the heart in, or do an anastomosis is what we call it, we do it usually in this fashion, just kind of a running sewing stitch like you would sew pants together. We call it a baseball stitch. The order that the heart is sewn in can vary depending on the surgeon or the exact procedure that the specific hospital has adapted. But in general, the left atrium is sewn first because I said it's the most posterior or furthest away. So we have to get that in there first. And then we usually sew the inferior vena cava, and then the pulmonary artery, the aorta, and lastly the superior vena cava. So we actually start with the heart flipped over and then start sewing and put it in the way it needs to go. This is kind of in the middle of the procedure picture where the left atrium's already been sewn, and here's the inferior vena cava being sewn. And this is the pulmonary artery being sized and will be ready to be sewn next, and then the aorta.
That's sewed by hand?
By hand.
I wish they were that big.
Yeah, they're not quite that big. Yeah, they're tiny. We use magnifying glasses. We all wear glasses that have either 2.5 or 3.5 or 4 magnifiers on them, so we can see a little bit better. And this is the end result, what it looks like. And this is a picture of us working. And see, these are the lines leading to the heart-lung machine here, bringing the blood to and from. The patient is then slowly rewarmed back to normal temperature during the procedure. Steroids and other immunosuppressants are given when the heart is starting to beat. And the heart starts to beat really on its own once the blood supply is reestablished. That's something that a lot of people want to know. How do you get the heart to beat, to start beating? It's amazing. You really have to do nothing but give it back its blood supply, and it just starts to beat. And then once the heart is in and beating and starts to get stronger and reperfuses for a period of time, we wean the heart from the bypass machine. So then all the cannulas that we had put in for bypass are removed. The patient is then dried up, meaning we look over and over again at all of our surgical sites, making sure that there's anything bleeding that needs a stitch, that we put it in and that the bleeding is tolerable. Chest tubes are placed then to drain the blood because there's always some bleeding, and so there's always tubes left in the chest. And the sternum or breastbone is then closed, usually with wires, and the patient is transported back to the ICU. So after surgery, the recovery, obviously you can't generalize about everybody, but in general, the hospital stay is usually around 7 to 14 days. Everybody's different. Some people might have even gone home earlier. Some people are in for 30 plus days. Slowly, the anti-rejection medications are started. The first biopsy is done in about 7 days. This is where a piece of the heart is removed and sent to pathology to check for signs of rejection. And this is done either through the vein in the neck or the groin. And then the patient and family obviously undergoes a great deal of teaching to understand about the medications that are involved, what to look for, what kind of problems to call for. So what kind of pitfalls can there be? Well, bleeding is one of our most common complications from a heart transplant. A lot of times people are on blood thinners. So going into this big surgery already on blood thinners makes it more likely that you're going to have some bleeding afterwards. If you have had a previous surgery, that makes the chance of bleeding a little bit higher. Infection is one of the risks. You could get pneumonia, urinary tract infection, or infection of the chest incision. Sometimes the right heart struggles. Usually the left side of the heart does pretty well after heart transplant. It's that right side that gives us a little bit of trouble. And it does that for a number of reasons, usually because the pressures in the patient's lungs are high. And that's not something that just goes away when the patient's transplanted. There are some things we can do to decrease the pressures in the lungs, such as a medication called inhaled nitric oxide that relaxes the vessels in the lungs. There's IV medications we can give to help the right heart squeeze a little bit better. And then if all that is not working and you're struggling to come off the bypass machine, we can place a temporary assist device or mechanical device to let the right heart kind of recover a little bit. And usually that can be taken out in a couple days. Acute rejection, that's a real problem. That's something that when it happens usually requires an assist device to be placed and may require relisting for an urgent retransplant. So, keys are organ donation, obviously, that's the key. The number of hearts transplanted in the United States has not increased in the last several years. We're still doing around 2,000 or so a year, and we need to educate and outreach to our community to teach them about donation. Thank you. Questions?
Jerry, would you up the light source?
Arrhythmia, to see it. Something arrhythmia.
Really? To see the actual heart or just talk about the...
No, it's just stitching, and I didn't go through it like normal people. When I've been into place, you woke up with a operation understanding. So I woke up, I couldn't walk or talk or anything, but I didn't know what happened. My head still doesn't know what happened. So to conceptualize it for me is difficult.
Yeah, I can imagine. I mean, that's one of the most urgent ways to obviously have to proceed. Yes.
Apparently. That's I can say.
Ready?
Yeah.
Hi. The first thing that I really asked you to touch on is the electrophysiology of the heart, the pulsating, and how is that connected? When do you start looking at that? We know that there are nodes, we know that there are veins and what have you within the heart that actually create the pulsation, the pump. However, is there anything that's done during the operation to reconnect this? And that's why I'm really a novice at this end.
That's a great question.
But it's an important one. And in fact, Dr. Hankins over at Harmony is going to speak about that subject on the 8th. But I'm just trying to educate myself before. I know that the pulse is broken into two parts, and the idea is, though, how is that connection made during the operation, or if it's made?
I didn't understand the question.
I know.
He's asking about the electrical activity of the heart. You know, it seems difficult to believe that you can take a heart out of somebody and put it in somebody else and it would beat without connecting some sort of electrical wiring. And so that's a very good question. The answer is that there are pacemakers in the heart, one that initiates the beat and others that propagate the beat, meaning take it from its origination place down to the rest of the heart. And if I could go back to my slide, I can try to show you where that pacemaker lives in the heart, which will help to answer that question.
Just the heart has a natural pacemaker in it. It's an automatic. So don't think of it as something that has to be put in.
How about that?
The pacemaker cells of the heart live about right here at the junction between the superior vena cava and the right atrium. So they originate here, and then electrical activity goes down the heart to the rest of it. Now, the way I describe the heart transplant to you today is not the way that we always did heart transplants. Currently, almost everybody does them this way, where we connect separately the superior vena cava and the inferior vena cava. But in the past, sometimes the way they did it was they would open this right atrium and they would keep the recipient's own superior vena cava and inferior vena cava and a little piece of the right atrium, and then just sew the right atrium on here. So it was one less connection you had to make. So it was one instead of 1, 2. And in those people, because that pacemaker lives about right here, they would have two what we call P waves, which are the beginning part of the EKG cycle. And so it would be very confusing because one of them would be from the donor heart and one of them would be from the recipient heart. And they didn't propagate. The one didn't propagate because it wasn't still connected, but it was there. So now we have the one, and it's from the donor heart, okay? And so you wonder, how does it get initiated? It's not attached to your brain in any way. This is something we don't exactly know all the answers to, but I can tell you that when we cut out the heart during the heart transplant, we don't stop the heart. Like if we were doing a bypass surgery or a heart or a valve surgery, we actually stop the heart with potassium solution and cold. So we don't actually stop the heart. We cut it out while it's beating, and as we put it on the pan in front of us, it still beats. Because the intrinsic pacemaker of the heart is still beating. So you don't need it to be attached to the brain in order to beat. So, it's very interesting. So, the one thing is that there are difficulties in transplanted patients' hearts in increasing your heart rate when you're exercising or having an emotion of such as anxiety or anger. That doesn't necessarily go up like somebody who doesn't have a transplanted heart, because it's not really connected like it used to be. But like I said, we know that the actual pacemaker activity comes from this part of the heart, and so it is intrinsic to the heart. It does not need to be attached to anything else.
To follow up then, the necessity of stress tests at each our physicals or our annuals, or whatever you want to call them, is simply to recognize the continuation of the pumping sensation in a proper manner. So what happens during the stress test, and why are there so many different kinds of stress tests?
Good question. So a stress test is usually done to look at the function of the heart in relation to the blood flow to the heart. Okay, so there's a correlation between the blood flow to the heart and if there are blockages or no blockages and how well the heart's beating. So somebody who has a significant blockage of one of the heart arteries may have one area of that heart that doesn't work real well, and the rest of the heart is working fine. So a stress test will show you that. And the reason that's important as part of your evaluation is that the arteries of the heart get affected by rejection, and plaque builds up over time with rejection. So they're looking for areas of your heart that may not be working well due to plaque buildup. And that way, if they found an area that they thought was not working properly, they would refer you for cardiac catheterization.
That's enough out of me.
There's no limit to questions. Bernard?
With the heart assist, or any heart assist, when it's in the body, can it move?
Well, it does move. I mean, it doesn't move a lot, but it moves because your heart's beating and it's definitely connected to your heart. And so as your heart beats, it makes the device move, for sure.
And what effect does that have on tissue in your body? Scar tissue?
Yeah, well, it definitely could, your body could react in a way that would form scar tissue, or it could cause you discomfort or a different feeling than you're used to.
The reason I ask is, when I was in the hospital, somebody had a vat, and they tried to remove it, and it had moved. And because it had moved, it took them 6 hours to get it out. In the meantime, the heart came, and he never made it.
Like I said, having an assist device or being in re-operation carries increased risk because you don't know what you're going to find going back in there. We can try to prepare for that, and that's the timing part that's key. And it's very difficult to guess, I shouldn't say guess, determine when to start the operation in relation to when that heart's coming back. It's a very difficult call. And if you run into unexpected circumstances, you could end up with a situation like that. Or, let's just say, I knew I had 2 hours before the heart was coming back, and I was going to take that time to get in there and get all that scar tissue out, but I wasn't going to go on the bypass machine, I'm just taking my time. Well, what if, when I go through the breastbone, I unexpectedly enter the heart, and then I have to go on bypass. So then I'm on bypass for 2 hours before the heart even gets to the hospital. That, that's a situation that's not good either, because the body can tolerate only so much of, being on the bypass machine, because it's not a normal situation for our bodies to be in. So those things happen, and they do come up, these situations, and we try our best to think ahead of time and prepare for them.
Barb was on ECMO. Can you explain the difference between the VAD and ECMO?
Sure. I will try my best. So ECMO, there's 2 types of ECMO. So what ECMO stands for, it's ECMO. Extracorporeal membrane oxygenation, meaning extracorporeal means outside the body. So those pumps that I showed,
We're in a machine outside the body.
and the actual pump was outside the body. This, I'm sure it looks something like this, they're not all similar. So extracorporeal, outside the body, membrane oxygenation means that the machine is going to oxygenate or give oxygen to the blood before it returns to the body. So the original reason for ECMO was really to support people whose lungs were not working. So, babies who are born prematurely, whose lungs do not work, you could put them on ECMO. It's a little different type of ECMO than we're talking about. Their ECMO would only be supporting the lungs, and their heart would be doing all the work of the heart. You can use ECMO to support the heart and the lungs, and that type, you take the blood out from the venous system, you put it back to the arterial system, and you need to oxygenate the blood, and you're doing the work of the heart as well. So you're doing the work of the heart and lungs. And that's a very temporary situation, because you can't stay in that situation for very long because the body starts having some issues with that in terms of blood breaking down and all kinds of different problems, liver failure or kidney failure. So it's really a temporary situation, and it does the work of the heart and lungs, whereas a VAD, a ventricular assist device, will only do the work of the heart, or maybe just the one side of the heart, the ventricle, but it doesn't oxygenate the blood.
I was only to be on ECMO then.
So ECMO is used in a very emergent situation where you have to do something where you feel that the patient is not going to make it.
Her lungs were filled with blood, and they wouldn't work properly.
Right, and that's a very typical reason to go on ECMO. We consider ECMO to be one of the most, urgent or emergent situations that there are, and there's actually not a lot of survivors from that, people who go on ECMO. Especially not adults. When it's used in the children in the situation that I spoke of with, immature lungs, they actually do better because it's not being used in the same way. It's not really being used to support the heart. The heart's working. It's just used to support the lungs.
Not many adults survive it.
Sounds like you're one of the lucky ones, Barbara.
Very, very, very few. We actually pretty much call it a heroic, it's one of the heroic efforts. And you can't, not every hospital is equipped to do it, actually, because it requires a special team to be present, to do it urgently. It requires the machine to be set up and ready. And if you go to a community hospital, they certainly wouldn't be able to put someone on ECMO.
They said she was lucky down at one hospital. They said, we just happen to have one that's supposed to go back and happened to be here.
Sounds like it's a pretty urgent situation.
Do you know if there's any research going on with regards to being able to have a heart transplant without cutting the ribs?
Not at this point in time. I don't think that can't foresee any way we could get the heart into the body without at least that big of an incision.
That's a good question.
No, not yet. Not
We are working on ways to transport the heart from the donor site to the recipient site and have a longer period of time that we can keep the hearts beating and therefore have more time to get the recipient ready and get the heart in and working. So instead of stopping the heart at the recipient site, the donor site, and taking it not beating back, there's an actual machine that you can hook the heart up to that will keep it beating during transport and keep it being refreshed with nutrients so that it's not really ever stopped. So that's exciting. That's kind of
The arteries that you reconnect, how long I guess the stitches dissolve?
No, these are non-dissolvable.
Oh, they stay in?
They stay in forever.
And the two pieces of artery, they heal themselves together?
Yes.
2 weeks?
It depends. I think it takes a little bit longer than that.
Longer than
If you
that?
go back in 2 weeks and I cut the stitch, it would all come apart.
Okay.
Yeah.
That's probably why they say not to drive between 4 and 6 weeks, because they can injure that part. Something would happen.
Well, that's mostly for the healing of the breastbone, the sternum, because that's like a broken bone. It's like if you broke your leg, they put you in a cast for 6 weeks, because you have to immobilize it in order for it to heal. And so it really takes the breast bone 6 to 8 weeks to heal. And so that's why we don't like people driving or doing any heavy lifting for a period of time.
What kind of wires do you use?
And what?
What kind of wires do you put in?
My stainless steel wires.
And then you take them out, or?
No, they're
still in there.
If you see an x-ray of yourself now, you'll see this
You
wire.
see the wires?
Yeah.
Oh, my God.
Now, we have been recently using plates and screws on some people. It depends on the patient's body habitus and how big their sternum is and what kind of, activity they're going to be doing afterwards, that kind of thing.
It goes on a scanner.
Linda, can you talk a little bit about the nerve regeneration post-transplant to the heart?
Well, that's what I'm saying. We don't know much about that. We know there is some regeneration of the nerves that hook up to the electrical activity and for the heart rate control. But I don't think we know as much as we're going to know in the future. So right now, I can't say a whole lot about that.
Is there a lack of control because it was severed? That's why you need some of the drugs that you have to take?
Yeah, it's
regulate?
interesting. If you are at the donor hospital and at the time you get ready to take the heart out, the donor's heart rate is 115. When you put it in, it's probably about that rate.
And it stays high.
Yeah, it does vary. And sometimes the problem with these donor hearts is that the heart rate drifts down too far. It's almost never that it's too high. We actually like the heart rate initially to be pretty high. Because the heart just needs to be in there and working. Sometimes if we come off bypass and the heart's going only at 70 or 80, we actually pace the heart temporarily because we put temporary pacing wires on all the hearts. And then over time, we hope that heart rate will go up. And if it doesn't, we can give certain medications to try to increase the heart rate.
Linda, is there some situations, and I'm asking the question because it's been explained that was my situation, where instead of leaving part of the heart in and stitching it to it, they replaced the entire heart? And the reason I say that is originally in that first follow-up EKG type situation, they were imaging it, and the person who reads those came in and said, "Oh, Mr. Gleason, I've been following your imaging for quite some time. Nice to meet you. You're in a dark room and laying there, and this woman's massaging your chest, and doing this. It's a great test." And she started interpreting as she was watching it. She says, "Wow." She says, "You know anything about your heart?" I said, "No, not really." She says, "I would say it's a very young heart. You've got a let's see, what are the E-wave? I had an I-wave. And I never heard of an I-wave." And she explained that sometimes it's a very athletic heart. Well, I'm glad to hear that. And she said it beats so strong that there's a backflow which creates yet another beat. And I'm not sure if that wasn't maybe what you're talking about here. And she says, "Wow," she says, "this is really a nice piece of surgery. I can barely see the stitch line." I was even more pleased. Dr. Acker did a great job. And it was only later on when something happened that they had to do some, the heart, about 2 months later, started racing. It was up around 180. And so they were going to go in and shock it. And they said, "Do you mind if we do some studies while we're at it? This happens once in a while. We're trying to figure out why." Hey, go ahead if you can. And so while they were in there, they were doing quite a bit of work, and they were trying to short circuit the pulsing to find out where it was coming from. And so I was very interested in watching the whole thing, etc. And the next day when they came in, I said, "So what did you learn?" Their theory was that it was short-circuiting across the suture line. I said, "Oh, okay." So the next day they came in, I was very curious as to what they learned. They said, "Well, we didn't learn anything because in your case, you didn't have a suture line." She said it was a type of heart transplant where they replaced the whole heart. I've since done some reading. I can't remember the words for it, but I've always been curious as to how common that is as opposed to what you described here, which is the typical one. Does that make any sense at all to you?
Well, I don't even know exactly what you're speaking of because I've never seen a heart transplant done without the cuffs that I showed you.
Right.
That are pretty much required to suture it in. The only difference being when they, in the past, when they didn't hook up the superior and inferior vena cava, but did the right atrium to right atrium, you actually had more tissue, you had a double right atrium, basically.
Right.
But in general, if you looked at an echo of a heart transplanted patient, you would be able to tell that it was a heart transplant. So that's not uncommon, that's common.
I've got the word in my book here, maybe I can look it up here later, and if maybe you'd recognize the word for it, I can't remember, it's been too many years. Isn't that great?
Do they have any more, or are there any immune drugs coming online that are better than ones that we're taking now?
I'm sure there's all kinds of stuff that they're working on now. As you know, cyclosporin was the first immunosuppressant that everybody used, and now most people use Prograft instead of cyclosporin. Steroids are pretty much a mainstay, except that some people, when they get out a certain number of years and haven't had a lot of rejections, they could come off the steroids, or at least come down really low. But, that varies by program and by patient, and so you can't really be a generalization about that. But they're always working on new anti-rejection medications.
Tiny little pill instead of 14, just a little?
I would suggest that.
I'd be curious, what percent of your patients come off prednisone?
No, I don't actually know, because it's really the medical, the cardiologist that
They
follow the
yeah.
immunosuppressions.
After a year.
Off the steroids.
Yeah, often 3 months. Steve, you still on prednisone or Rob?
No, I was off in about 3 or 4 months.
I'm still on it.
Yeah. Bernard?
A year was good.
You're off it, yeah. I'm hearing most people are off it these days, that's why I was just
Yeah, I
curious what
know more programs are going to really trying to get him off the steroids, but, it's really patient dependent too. I mean, if you've had a lot of rejection episodes,
Yeah, of course.
they tend to keep you on it.
Yeah. How about AlloMap? Has that been adopted as a standard now? AlloMap, the blood testing for rejection?
It's not a standard, it's an option, it's something that we use for some people. I don't know what proportion of the patients we're using. What he's talking about is a blood test to check for rejection instead of the biopsies that are more invasive. And I think eventually it's going to go all to just a blood test, but we're just not there yet. It hasn't shown perfect correlation with the biopsies.
But I think it's obvious there's still a lot of trial and error, and it's going to keep on going that way, but we don't know everything, and we know it. So the idea is that's kind of
We're learning.
continuing and learning. We might not see it in our lifetimes, but I certainly think it's in the right direction.
Well, it's interesting, when Dr. Eisman was here, one of the things he commented when he stayed around and talked later, is his attitude is we've been over-medicating our patients post-op for a long time, and they're, in that particular program, which is your Hahnemann program, more and more, when you see rejection, they don't treat it, they monitor it, as opposed to trying to do anything with it, and he said the body typically handles that. Now, acute, yes, but in general, he said we've been overdoing it, and it's an interesting theory, which he's got in practice. We are very fortunate here in the sense that we have so many very generous medical professionals who come and share this stuff, and there's a lot of hearts around, okay? We have 800 in Second Chance as an example, and you have to be a heart transplant recipient to be a member. We've got 800 that come out in all different ways, and Dr. Eisen, as an example, comes and he just sat around for another hour after the meeting was over with the Second Chance group, and we have that fairly common. So you get a lot of insights that we are all very interested in, and we really appreciate your time tonight and the insights you're sharing here. Every time we do, we learn more, we challenge our thinking, we find out something a little bit different, and sometimes it's changing, sometimes it's correcting misinterpretations, and God knows we've heard enough things in our own clinical practices there to get it wrong many times, huh?
I have a question. Are you on call like 24/7?
Unless I'm out of the country, or out of state, yes.
Well, thanks for coming out.
Can I introduce another topic?
If it's on topic.
I don't even know if it's in the, Randy might be able to help me with this. the idea of the donation, and the latest is that the living wills, everyone is asked to put together a living will, that it's no longer really what you think it is. To the point that the doctors now want to be involved in the decision of when to give the heart. Too often in the past, it's been up to the family. The doctors want to be part of the decision-making, and rightfully so, but there's a lot of room for that. Why do they want to be involved? What I'm thinking of is right now, you have the feeling of the donation itself is something that's strictly to do with the family. The wishes of the deceased.
Bernard,
Go
can I
ahead.
interrupt you? Legally, in all 3 states now, it's no longer the family's choice. It's yours.
Is that what happened?
Legally, now, in practice, maybe a little bit different, but all 3 states have now joined 37 other states in making your wishes the primary. Once you indicate organ donation,
Yes.
the family cannot overrule it legally.
Mhm.
In practice, they might, based on how gift of life handles it and somebody else. But in fact, they do protect legally your right.
But I'm saying now the doctors would like to be involved in that decision making.
In what way?
They are, I don't understand.
Well, they are because, first of all, they have to be part of that team. And look at what that decision does on the doctor's behalf. They're being told that they're waiting at the donation table for the heart, and now comes the idea of who gets what, and when these things come up to play. Yeah, all this is now being tested. Hopefully, this thing can go right to a point of understanding. The last piece is where the choice is being made on who gets what.
It has nothing to do with.
I was going to say, yeah.
That has nothing to do with
Nothing to do with it.
Nothing.
I'm like so lost.
That whole allocation process is out of the hands of the doctor. They get the offer, they can accept or reject, but they have nothing to do with the allocation. I mean, that's strictly guidelines that are codified by UNOS and followed by the Gift of Life and other organizations. So I'm not sure what you're talking about at all.
All right, I'll have to just research that a little more.
Yeah, bring it back.
I've been reading it, and
I'd like to see where you're reading, if you can share it. Well, then maybe we could make some understanding of that.
okay.
Liz, you've been in the heart transplant field for how long now?
16 years.
16 years as a social worker. What have you seen change over 16 years from your perspective? Now, you're not a nurse, you're a social worker, and you've always pointed out to us, so I'm clarifying that for this recording. What have you seen change in 16 years?
Everything and not enough. A lot of it is still the same. Mostly, I would say what I've seen change the most is the perception about disability and not being disabled after transplant anymore. That's
Talk about that a little
huge
bit.
shift. Just 15 years ago, when someone had heart transplant, it was deemed that they would never be employable again. And now, in our program, we've had someone return to work in 8 to 12 weeks post-transplant, just by virtue of how quickly they recover and what they do for a living. So it's been very refreshing and something that I'm sure donor families would love to hear about. I've not seen enough legislative change to keep up with the demands of ongoing expense, taking care of transplanted organs and medications. And I've not, obviously, like everybody else, seen enough donation increase to meet the needs of all the patients that we have waiting for.
Do you feel that the education of the candidate is strong enough in terms of understanding the donation side of things? I mean, I know Pam has often been frustrated with, from a donor family side, that patients think that the doctor gets the heart or the heart, liver, or whatever, and she's very frustrated that they aren't educated that somebody has died and made a gift, but instead, God, the doctor, has gotten my organ, which is,
Yeah, I think it's a good point. I think at our center, we try and do a very good job of educating without, and I think you have to be careful about the emotional and psychological state of the patient. There are some people who in the past have truly struggled with survivor guilt or, bleeding or separating on this idea of even exchange. And so we try and do a lot of education about that, at the same time not beating them up with a heavy lift. We do more post-transplant about that when we feel that they're more psychologically stable and medically stable and tolerated that discussion.
Linda, coming back to you if I may, and this one sounds off the cuff, it's not. We have our quarterly transplant movie night, for example, and the most recent one was The Heart of a Stranger, and it was about Claire Sylvia and her heart-lung transplant and the inheritance of traits and memories from the donor. As a surgeon yourself, do you have any thoughts on that? Do you believe there's a possibility? Do you think it's all bunk? What are your thoughts on that? Cellular memory.
Well, I haven't really thought about that.
Really?
No, I guess, we're...
I don't mean to take you off something you haven't thought about that.
Well, I'm just like a real clinical, physiologic type of person in terms of what I do. I mean, I'm very spiritual in my own, life and have those kind of beliefs that are very strong. When thinking about heart transplant and sewing the heart in and then bleeding, I guess I never really thought about that aspect. And I've never had any patients talk to me about it, so it hasn't been something that's brought to my thinking. But I'd be interested to hear from any recipient if they feel that's
It's not something that we heart recipients talk to doctors about because they think we're crazy if we do. I haven't had any such experience. I'm not advocating for that. I'm just saying this is not something to go back to the doctor and say, hey, doc, guess what? But it is probably one of the most common subjects that community bring to us as patients. Have you had any such experience? Have you had this happen? And so it's a very common concern, but lacking scientific, there's a lot of secondhand stories, and beyond that, haven't.
You're talking about cellular
I'm
memory.
talking about people after transplant having memories that came from the donor.
Well, it had to come through the cells, that's the
Correct.
only place.
And that's why it's called cellular memory, as one of the theories of how that happens. And so here's this young girl who receives the heart of a murder victim and has recurring dreams of what the murderer looks like and describes it to a police artist. And they find the murderer, and sure enough, it matches that.
This is TV?
I'm sorry?
This is on TV?
No, this is real life interviews.
I've heard more things like, I never liked peanut butter before, but now I love it. And you find out that the donor really likes peanut butter. Or,
Right.
Sort of things like that. And no one really can say yes or no, but I think, I probably hear more of that than the surgeons or cardiologists.
Probably, yes.
It doesn't really come up in the context of the office visit, but my standard answer is, I think that's wonderful because, part of that person's personality or spirit lives on and if it works, great. And a lot of times the donor families just love to hear things like that. They love it.
I thought I had it made. When she woke up, all she wanted to watch on TV was football.
That's true, I didn't know until I was done.
Well, they told me it was probably the activity going back and forth on the screen.
It's like a husband's dream come true.
Yeah.
When she couldn't talk.
It's something that I've come to realize over time that in the areas of medicine, there are so many specialties. And so, for example, realizing that a surgeon, what do? They're in the surgical room. They don't get to follow up with the patient beyond that initial period. And so they don't get to see what it's like a year or even beyond. Social worker gets to see another side of it. The typical balanced patient probably doesn't get to do much with a social worker. I can't imagine what your view of patients are, since you're treating those that are in looking for some social worker support, the rest of them. And it goes back to one of our initial conversations. When she was at HUP, after one of the transplant games, somebody came back and said, 85% of heart recipients remain disabled. And I said, there's no way. I mean, I'm out in groups like this, and people are doing things and, living a normal life. And yeah, they have challenges, but it's a very different world. And I didn't realize that. And I said, that can't be. And I went to Liz and I said, what's our local experience? And she said, well, it's higher than we would like to see it. It's probably in the 70% range or higher. And this speaks to the surgeon, because she said, our problem is when people get to a point 6 months out or 9 months out where the recovery is that complete, they don't qualify for disability anymore, and they scream and holler because they have to stay on disability. And to quote you, our doctors didn't do a transplant to make them disabled. And so that's how we ended up having a workshop. You thought I didn't listen to you. And we had a workshop here with about 25 patients and caregivers, where we brought in people from UNOS. We had people from the hospital talking about the timeline of recovery. We had studies from returning to work across the country, et cetera, et cetera. And it was very interesting to realize that a lot of it was the perception that patients had when they left. And that was interesting, you said this before, it's changed over time. And it was funny because when we put out the invitation, we put it out to the HUP list. HUP was sponsoring this particular workshop. And we had 3 people who wanted to come that were in their 70s. And they said, listen, we only have a limited number of seats. They're not going back to work, so why don't we hold off on them and keep the seats open? It makes sense to me. But then, when we still had some room, I said, I have to get back to them anyway. And she said, yeah, go ahead. I couldn't get in touch with any of them. 73, 74, and 75, because they were all out to work. And I came to realize after hearing their stories out there, I said, I need them on a panel here to show the other patients, And they were people who, very fortunately, had been able to return, and that's not everybody's opportunity. And so many at an later age get these, that they're ready for retirement, or didn't like their job in the first place, don't want to go back to work. And so there's a lot of variables. We changed it from getting back to work after transplant to living a fulfilled life after transplant. How be it for us to tell somebody to go back to work, And that changed the whole venue, but it was amazing to see the stories we had to share with people in the breakout groups, et cetera, in terms of expectations. And so, very interesting to see what various medical professionals see within their frame of reference and the impact of that.
If I could add just one thing for that, I was in the hospital, I think, for 9 days, because they wouldn't let me out after 7, except I had a blood clot.
Every time.
On the 10th day, I went back to work. I felt that good. I was on my computer and phone conversations, and within 5 days after that, I was making appointments and going to appointments. And my offices are in Park Avenue, New York. I wasn't going up there, but I was making appointments. I felt great, and I've never looked back since. I don't think it was, I think I could have left that morning of the operation, but I had a lot of baggage.
I
Felt great.
have a young woman's heart. And the only thing I can think of as far as the psychological end of it is right now, I'm thinking that I'll get my period every month, but that's not true.
You guys,
I have to go to work. I'm sorry,
I was
guys.
always 5 to 6, and now I have to go back to work at 9. Pay the rest of it.
Thanks for coming, Mike.
Thank you.
Appreciate it.
Everybody.
It's a real opportunity, Linda, for us as patients to be able to be here, hear you this way, and also be able to say thank you for what you do. And for us to tell you, it's been worth every minute of it, this life you've given us. And if you add up, Jerry, how many years now?
10.
Barbara, how many years are you out now?
8.
18. How many years out? 25. 16, that's 41.
18 months.
And 2 more. So there's 43 years just in this room alone. And I'm going to tell you, when we have meetings, it's not unusual for the hearts to outnumber everybody else. And we know that the kidneys are 80% of them, okay? but the hearts are out there doing things, trying to change the organ donation perceptions out there, and living life to its fullest. And those kidney people are envious. So keep up the good work. Linda, thank you very much.
Sure, you're welcome. Thanks